obsessive compulsive disorders, as well as schizoaffective disorder and psychotic depression, the subjects of Audio Digest Psychiatry, Volume 26, Number 3. Louis R. Baxter, Kathy Ireland Professor of Psychiatric Research and Pharmacology, and Vice Chairman, Department of Psychiatry, University of Alabama at Birmingham, discusses comprehensive treatment of obsessive-compulsive disorders.
Unlike schizophrenia, which was only defined in the early part of the 19th century, there are descriptions of OCD as far back as their historical records, and in fact the Romans used exactly the same terminology. I'm going to be pedantic here for a moment, and that's because despite the fact that for at least 2,500 years the words obsession and compulsion have meant one thing for most of history, in the last 10 years some other people have debased the meaning, and we've got to be very clear from the start what I'm going to be talking about and what I ain't going to be talking about. The word obsession comes from the Latin meaning to besiege. These aren't just thoughts that come over and over again. They're ones that are what we call ego alien. Person knows that they're his thoughts, but they're disturbing, they don't make sense, they're perceived as excessive, and that's very different than, let's say, ruminations. The patient who comes up to the nursing station again and again asking to be checked for cancer may be called by the nurses in the station obsessive, but often Mrs. Jones here is ruminating. Mrs. Jones really is afraid she might have cancer. Whereas the OCD patient, at least at some levels, knows that this is weird stuff, and the emotions are different than one's reason that tells you that this is probably not the case. We've got this problem with what I call DSM-10 diagnosticians. If you don't know them, your patients do. They're people like Donahue, Ofra, Geraldo, Sally, all these people that are labeling anything that is undesirable that somebody does again and again, obsessive or compulsive. The problem is OCD is a Pac-Man type diagnosis gobbling up other kinds of nomenclatures. Now, some of these difficulties, things like Gilles de la Tourette syndrome, onchophagia, chewing one's nails down to the quick, those do seem to have a tight relationship with OCD, both in treatment response, etiology, genetics, etc. But some others, including things like trichotillomania, paranoid jealousy, eating disorders, very, very far from clear whether there is an etiological relationship, and also treatment considerations tend to be different in a lot of these disorders. I'm going to be talking about OCD proper today and mentioning briefly things like Gilles de la Tourette syndrome and secondary depression in OCD, and not talking about all this other kind of stuff. Okay, well, I'm not obsessing here, I'm ruminating that this kind of behavior is experienced as intrusive and senseless. It causes distress, it's ego alien, and the compulsive behaviors are usually one which on their surface would tend to neutralize the anxiety caused by these troubling thoughts. What I'm saying here is, of course, review for all of you, but I think it's important because our patients come through confused. Obsessive thoughts, tabulations of 250 patients, and most common are contamination, fears, pathological doubting, needing to check things again and again. But I wanted to point out two things here. First of all, the fact that most patients have multiple obsessions, and in fact obsessions tend to shift over time. Someone who is concerned about contamination one year, the next year may be concerned about symmetry or incompleteness. In this way, the thoughts are like the motor tics in Gilles de la Tourette syndrome. They shift over time. They don't tend to be set. Aggressive and sexual impulses. These people get consumed with horrific thoughts that they may try to harm someone or perform some unacceptable sexual act. They don't do it. They're terrified by it. They have this sort of cringe reaction to what many of our patients describe as horrific thoughts. It's one of the more troubling kinds of symptoms, and one that your patients are not likely to tell you about. The compulsive behaviors, they usually make some overt sense. People that are concerned with contamination tend to do a lot of washing. Checkers are people that are concerned that they haven't done something correctly. No big deal there. And not surprising, many patients have multiple compulsions and they shift over time. Most of your patients have both kinds of symptoms to about the same degree of severity. 1-to-1 severity on the Yale-Brown scale of obsessions and compulsions. If they're going to have a predominance of one over the other, it's obsessions. And you do see patients who only have obsessions but not overt compulsive rituals. But that's not the rule. Very rare are patients who deny any of the troubling thoughts. Many, if not indeed most, patients with OCD, the illness starts in childhood. Many patients start before grade school. The illness tends to wax and wane over time. It may be there severely, let's say in grade school, not there so bad in high school, and come roaring back in mid-adulthood. It's rare to have true first onset after age 35. In fact, if you have a patient who comes to you with severe OCD and he and family members say that there was never any behavior like this before, not a bit, you have to be highly suspicious of a structural lesion. Small strokes into the basal ganglia and meningiomas on the undersurface of the prefrontal cortex are two of the more common causes for secondary, if you will, traumatic OCD later in life. Pre-pubertally, most patients with OCD are boys. But once you come into puberty, the girls really start to catch up so that by mid-adulthood, the ratio is approximately equal, males to female, or perhaps a little bit heavier on the female representation. But this is not the case in the young kids where there's a male predominance. Now, there's a lot of evidence that OCD probably has a genetic underpinning. This really isn't surprising. Sigmund Freud stated very clearly in his discussions of the disease that he thought it had a constitutional underpinning, a biological predisposition. In recent years, data has been accumulating that strongly suggests that, at least in the forms of OCD that run in families with Gilles de la Tourette syndrome, that there may be an autosomal dominant gene underlying the probability of whether you might get OCD or Tourette's. Almost all patients with OCD get a major depressive episode at one time or another in their life. At cross-section, at one time of presentation, about 1/3 of them have a concomitant secondary depression. The depressions, though, tend to come and go. The OCD, although it waxes and wanes with a very long periodicity, rarely goes away. When the depression is superimposed on OCD, the OCD symptoms usually, though not always, get worse. About 90% of the time, the depression that OCD patients have is a unipolar type depression. Roughly 10%, at least in our clinics, have bipolar type depression in OCD and have mild hypomanias. There, the adjunctive use of carbamazepine or valproate seems to be helpful with the other interventions I'll speak of. Well, I've mentioned depression. There's some other things that are comorbid with OCD. Depression, about 1/3 at any one time having major depression. Phobias, simple phobias, close to half of patients, but these often aren't problems. They're spider phobias, snake phobias, usually no big clinical problem. Panic disorder are about 10 to 15%. You need to take special attention to substance abuse. Both alcohol and other kinds of substances have a fairly high rate of abuse in OCD patients. Here we have two patterns, however. The less common of the two are patients who have concomitant true primary substance abuse and primary OCD. There you need to address both equally, and things like AA are often important. However, many studies indicate, what we've found in our center both at UCLA and in Alabama, is that most of the patients have secondary substance abuse. These are people who don't tend to have big problems, let's say with alcohol, when their OCD isn't acting up badly. But when it flares up, they hit the bottle. The mom who's on her hands and knees scrubbing the kitchen floor for the 87th time on her way to 100, and it's 4 in the morning, will sometimes reach for the bottle of vodka just to pass out. In those patients, treating the primary OCD usually does wonders for the substance abuse. However, you may have to dry the patient out, perhaps in the hospital, treat the OCD, and then they'll do fine without any further substance abuse intervention. You might early still have to have a specific substance abuse intervention. Why are you the way you are? Well, probably some of you ask that occasionally about a lot of people. But in my experience, nobody asks this question more persistently and insistently than OCD patients about themselves. This is highly ego-alien behavior. In the context of talking about treatment interventions, I'm going to be sharing with you some of the things that we and others have learned over the last 5 to 10 years about what might be involved in the production of these symptoms through brain mechanisms. The most venerable answer to this question about OCD, however, is demon possession. If you talk to OCD patients, many of them will tell you, and I have a number who are psychiatrists, psychologists, they'll all say, I don't believe in demon possession, but I sure understand how people might have drawn that conclusion. It really feels like you're being taken over by feelings that compel you to do things at the cost of great anxiety that consciously you don't want to be involved in at all. Well, this was the vision of OCD up until about 200 years ago. We've had many since. Today we're fortunate in having functional brain imaging tools that do allow us to get measures of physiology in the human brain and to try to correlate these with disease symptoms. This afternoon I'm not going to give you a scholarly review of all of this literature in OCD and related subjects, but I do want to give you some ideas of what may be going on in the brains of your patients producing this kind of weird behavior. I want to do this for 2 reasons. One is physicians, you should probably know about this, but secondly, your patients may find it beneficial. Many OCD patients, they tend to be quite well read, do take a great comfort in the fact that this is not something that they're, quote, doing in a bad moralistic sense. Most of them have been told for many years by other people, just stop it, you're just doing this to annoy me, etc., and have tremendous loads of guilt. It is often helpful for them to understand what might be going on in the brain that makes it so hard for them to do what they would like to do logically if they were only free of these troubling emotions. One of the earliest findings in OCD was that the orbital cortex of the brain right up over the eyes is extremely active in OCD, compared both to normals and to patients with depression. We reported this almost 10 years ago now. No big surprise here. Ever since Phineas Gage, 150 years ago, got a blasting powder tamping rod shot through the top of his head and ablated this area, we've known that people that have lesions here tend to have behavior that's often described as the opposite of OCD behavior. Whereas the OCD patient is overly concerned about expressions having to do with violence, hygiene, sexuality, things like that, the person with lesions here could care less. Also, rarely there are people who have seizure disorders in this region of the brain, and they sometimes show OCD symptoms, so no big surprise there. This finding of high glucose metabolic rates, glucose is the energy supply of the brain, this finding of high brain activity in OCD is not seen in other disorders. For instance, it's not seen in chronic negative symptom schizophrenia. These are PET studies from Dr. Buxbaum, who's now at Mount Sinai, used to be in California. If you take a normal and you give him or her a task that requires a lot of activation in this orbital region of the brain, they can crank up activity here, generally not as high as the OCD patients, but schizophrenic patients, even doing this task, tend to have very low functional activity in this orbital region of the brain. Now, in major depression, we see something different still. In both bipolar and unipolar major depression, the lateral prefrontal cortex, front part, tends to have very low activity. And the decrease in activity is proportional to how bad the depression is. The worse the depression, the lower the activity. After treatment, this gets restored to usual levels of activity. Well, so far, the part of the brain that I've been talking about in OCD and a little bit in depression is the cortex, particularly the frontal cortex. But there are another group of structures deep in the brain, the so-called basal ganglia structures, including the thalamus, which for over 60 years people have hypothesized might be involved in the production of OCD symptoms. I'm not going to give you a scholarly review of why people thought that the basal ganglia might be involved in obsessive compulsive disorder, but I do want to mention two things. One, all of the classic neuropsychiatric basal ganglia diseases, Shields-de-la Tourette syndrome I've mentioned, Huntington's disease, etc., all have extremely high incidences of major depression and OCD with them. That was one of the early bits of evidence. Another thing, though, has to do with memory. Now, that may sound funny. Most of us, when we think of memory, think of what the neuropsychologists call declarative memory. What happened yesterday? The kind of thing that can get impaired in Alzheimer's disease. Now, in that kind of memory, we've known for a long time that things in the temporal lobe, particularly around the hippocampus, have involvement. But there's another kind of memory, what the neuropsychologists call non-declarative memory or process memory. This is the ability to do habits and skills, things that you pick up, riding a bicycle, writing your name without thinking about it, etc. It also has to do with conditioning and deconditioning, things that, as I'll touch upon, are very important in OCD. And here, animal studies have indicated for quite a long time that the region of the brain that's important is the basal ganglia structures, not the hippocampus. Well, before I present some more data about regional brain function in OCD, we're going to segue into treatment because, in fact, we use treatment as a tool to study what's going on in the brain in these individuals. Now, in OCD, we have two kinds of treatment that on the surface look very different that are effective, and they're both quite effective. One of the things is behavioral deconditioning, using what's called exposure and response prevention. It's a deconditioning technique. Quite effective. My good friend John Grice in Wisconsin calls behavioral deconditioning using exposure and response prevention endogenous pharmacotherapy, a reason we'll get back to. And so to get back at John, I call the pharmacotherapy exogenous behavior therapy because it treats the behavior. They're all psychotherapies. They all work on the illness. One is a behavioral deconditioning, one is a medication. Let's talk about these briefly. As probably all of you know, there are a group of medications, 3 which in the United States right now have official indications for the treatment of OCD, that are antidepressants, but they're also strong serotonin reuptake inhibitors. They're very effective in OCD, whereas tricyclic antidepressants that aren't strong serotonin reuptake inhibitors are not effective. In fact, clomipramine and desipramine differ only in a single chloride moiety. Clomipramine is very effective in OCD, imipramine isn't. These are structurally very different, side effects very different. The one thing that they have in common that's known is this effect on serotonin reuptake. They have other actions that do distinguish them from each other, but they have this one thing in common. Two other medications in the United States, paroxetine and sertraline, also have multiple double-blind studies showing that they're highly effective compared to placebo in OCD. The doses of these medications in OCD treatment are roughly equivalent to the ones that are effective in treating depression, or slightly higher. Generally in the studies, the more effective doses are slightly higher to twice as high. However, if your patient can only tolerate, let's say, 20 milligrams of fluoxetine or paroxetine, even if you know that they're likely to do better on 40 or 60 milligrams, they still do get benefit, although maybe to a lower degree, at the lower dose. So if side effects are a problem, you do want to continue at the lower dose. One thing that really distinguishes these medicines from the antidepressants, however, well, we're all used to antidepressants not working quickly. They typically take 2 to 4 weeks till you see a clear, robust effect. But in OCD, it's even more protracted. The most important takeaway thought I can give you is that adequate treatment trial in OCD of any of these medicines is nothing less than 2 months, and preferably 3 months, of one of these agents. Although you will occasionally see someone beginning to show some benefit within the first 4 weeks, and rarely even within a few days. It is quite clear that many patients show no clinically identifiable response to these medications 4, 6, even 8 weeks out, but then will go on to show visible response 2 to 3 months out. Likewise, once you have response at about 3 months, they tend to continue further improving for at least 6 months. It's extremely important to give an adequate trial. You may have the mismanaged care representative wanting you to switch drugs after 4 weeks. Don't do it. It's a total waste of everyone's time and, of course, of your patient's life. In OCD, these drugs are not equivalent. Statistically, they're all about as effective on the average OCD patient out of 1,000, but there are marked individual differences in response. There are actually bigger differences in individual response than there are in side effects. Yes, sometimes a patient will tolerate one of them much better than another side effects, but usually they're roughly equal. But for reasons we don't fully understand, there are patients who will respond robustly to one of these agents and not respond well at all to another one. In fact, in the paroxetine studies, almost everybody who entered, at least at our site, had exhaustive trials with clomipramine and fluoxetine with absolutely no response, and we still had 40% of them responding robustly to paroxetine. They're very, very different. The first thing you should probably do if your patient goes 3 months and shows no response to one of these SRI agents is not do some kind of augmentation as the first step, but is to switch SRI medication. If the patient is exposed again and again to what they find difficult and not allowed to avoid it or to have the compulsive response, you extinguish the anxiety and the response. People differ as to how well they respond to exposure and response prevention, just like they differ in medication response. It is definitely not true that all patients will respond to behavior therapy. Far from it. Just like it's not true that they all respond to SRI medications. With medications, approximately 2/3 with any one will get significant relief. What's significant relief? Usually about a 50% symptom reduction on rating scales. That makes big functional changes in one's life, but it's rare for the medications to cause the symptoms to totally go away. Likewise, with exposure and response prevention, it is rare for it to totally go away. The patients have to constantly keep resisting going back to it. Now, there are many ways to do this, and in fact, there's several good self-help books out for patients to help them do exposure and response prevention treatment. The newest is one of my colleagues, Jeff Schwartz, has written a popular press book called Brain Lock, which basically tells patients how to do exposure and response prevention treatment themselves and to work on deconditioning. Of course, one of the things you have to watch out for when you're doing this is the following. You obviously don't have the patients do things that are potentially dangerous. If the guy is afraid he might get AIDS, you don't send him out having unprotected sex, etc., etc. But it's extremely important that patients constantly be resisting the compulsive impulses.
Dr. Baxter's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 26, Number 3, returns to Louis R. Baxter on obsessive compulsive disorder.
It has been shown, in fact, that you can do anti-exposure and response prevention. Tell the patient, well, you feel like counting to 10, count to 1,010, so-called fatiguing. Well, 40 years ago, when somebody thought to try that, it maybe sounded good, wear it out, but it's in fact been shown that this makes OCD progressively worse and worse and worse. Whereas the resistance in dealing with the anxiety till it extinguishes is quite effective. Conventional psychotherapy. There are some misunderstandings about psychotherapy and OCD. It is true that psychotherapy, whether it's analysis, dynamically informed therapy, supportive therapy, you name it, by itself will not treat core symptoms of OCD. Deconditioning helps, the medication helps, but you can do all of the dynamic work you want and it doesn't tend to budge. However, that is not to say that psychotherapy doesn't have a place in the treatment of the OCD patient. In fact, in most patients, it's extremely important. Why? A minimum of 2 reasons. One, patients will sometimes have true psychodynamically based resistances to doing the deconditioning or to taking their medication. Are you familiar with that in some of your depression patients? More commonly, however, are the problems that patients with a severe chronic illness like OCD face in trying to get their lives reintegrated. You can't just give somebody a pill or work with deconditioning who's had OCD for 40 years and expect that, oh fine, you're now cured, go back and have a family life and work. These patients need lots of supportive psychotherapy, a lot of vocational counseling. It's sometimes very effectively done in a group setting. Patients with OCD tend to be very supportive of each other, and we found some of the best ways to use supportive and mixed dynamic work is in the group setting. Be very careful. A lot of my colleagues, and they're making a good point, that psychotherapy doesn't treat core OCD, and that is true, but that is not to say don't do psychotherapy with OCD patients. God help us if the mismanaged care people interpret that you should just be giving a pill and deconditioning and not talk to your patient. You're going to have bad results. Well, I've been talking about these 2 kinds of treatments as if they're an either-or. But in fact, clinically, we use the 2 together. And you get better results for most patients using the 2 together. For one patient, you may have to start medications first and another behavior therapy, etc. But almost all of our patients at one time or another end up with both. However, for research purposes, what we can do is compare and contrast the 2. With good response patients, you can get virtually the same clinical result, the same kind and degree of symptom reduction with either behavior therapy alone or SRI medication treatment alone. And so in the research setting, we can ask, what is it in the brain that changes in a similar way? and proportional to how much the behavior changes when patients are treated with drug alone or behavior therapy alone. Now, we've published a number of studies on this. What we've now seen in several studies is that when patients are treated with either drug alone or behavior therapy alone, that this basal ganglia structure called the caudate nucleus, a great big area of the basal ganglia, decreases its functional activity in a certain region proportional to the degree to which the patient improved. In other words, no response, no change, half response, half change, etc. And that's proportional to the treatment response with either. The right caudate nucleus decreases with effective treatment, and also this orbital region of the brain right up under the eyes, it shows a change. It's a little more complex story than the caudate, but basically both of them moderate activity with effective treatment, whether it's drug or behavior. Now, the region of this right caudate nucleus that shows the significant change with effective treatment, that's in the medial ventral part of this structure. That's important for two reasons. First of all, that's the part of this caudate nucleus structure that gets the input from the orbital region of the brain and other parts of the limbic system. In other words, the region that shows the change is the one that is interacting with the orbital cortex and other limbic type cortex. Interestingly, this is also the region of the brain that has the highest binding of the serotonin reuptake inhibitor drugs. All of the SRI type drugs bind very highly here. Other antidepressants don't. And this is the same region of the brain that shows the significant changes with treatment. That's probably not coincidental. Well, we have looked at OCD patients before and after improving them with drug or behavior therapy. Good friends of mine at Harvard have looked at the other thing. They've taken OCD patients and temporarily made their symptoms worse. The same regions of the brain that we show decreasing with effective treatment, they show increasing with temporary symptom provocation. For instance, at scan 1, they might touch the patient with a clean towel. Scan 2, a dirty towel. These feelings of wanting to wash. The obsessions go up. There's a confound here because they've got to hold back, and so there's some resistance. But what's shown here is that when you increase this, these basal ganglia structures increase their activity, caudate nucleus, orbital region, and then a few other things. So that's, we thought, rather nice. What we show decreasing with treatment, they show increasing with provocation. Now, the specifics of the brain system that might be involved in mediating OCD behaviors. From the cortex of the brain, all parts of the cortex, there are strong inputs into the basal ganglia. They come into, for our purposes, the caudate nucleus, and then they go from there down one of two pathways, a so-called direct pathway to the thalamus or an indirect pathway to the thalamus, and then back up to the cortex. Take my word, if the impulses go more through this direct pathway, the thalamus is disinhibited, and you set up, in fact, a self-driving loop that goes over and over and over again. This is what we think is going on in OCD. Whereas if more of the impulses are sent down this indirect pathway, the thalamus is shut down, and that breaks up this activity. Now, in normals, there is a balance between these direct and indirect pathways, neither too much release nor too much shutdown. In the OCD patient, there's too much tone going through this direct disinhibiting pathway that gets the thoughts stuck again and again and again, and not enough intervention to shut it down. And the reason we think that, besides a lot of animal studies that I don't have time to review, is that before treatment, there are significant correlations, relationships, between activity in the caudate and the orbit and the thalamus, and these go away after treatment. These pre-treatment correlations, the locking of activity between these structures, is abnormal. We don't see it in normal control patients, nor in patients with depression. And again, I don't have time to go through a wealth of animal data supporting this, but what we think is happening in OCD, there's too much drive through what's called the direct basal ganglia pathway. It's a disinhibiting pathway. And it goes round and around, if you will, this circuit like a broken record. Things really get stuck because there's not enough tone in the indirect pathway, which normally would be shutting this off when it's time. Treatment, and this is animal studies, seems to restore the usual balance between this direct and the indirect system. Serotonin is a major actor, is undoubtedly, from lots of evidence, what's involved in switching, in part, in switching the tone between these direct and indirect basal ganglia systems. However, there are many, many serotonin systems in this region and receptors. There are 19 of them, in fact, that are cloned to date. They're probably totally 119. We have increasing evidence that these 1C, or they're also called 2C now, and 2A receptors may be involved in what's going on in OCD between these direct and indirect pathways. Risperidone, which blocks serotonin 2A and 2C receptors, in recent studies that we've done and at Yale, is very helpful added to SRI medications in further reducing OCD symptoms, particularly in these patients that have the horrible thoughts that they can't get out of their minds. And we believe that probably is because of the 2C, 2A serotonin blockade that's put in on top of the SRI interaction. But to prove that, we have to do more work. Thank you very much.
What about the use of anafranil and Luvox together for OCD?
Well, anafranil clomipramine is a tricyclic antidepressant. Really, the only thing that you have to be particularly concerned about is increased tricyclic levels if your patient is one of the ones that slows metabolism. Let me say something about this for a moment. Every one of the SRIs can slow hepatic microsomal enzymes in the P450 series. There are a lot of them. It's not just 2D6 that's important, 1A3, and there are a whole bunch of them. Every single SRI can do it. The bigger differences are among individuals. Some individuals have high titers of these enzymes, don't get affected much. Some have low titers. Unlike with most things that we're used to with our psychotropic medications, where Asians tend to be the ones who get in trouble with high levels, let's say with tricyclics, statistically it's more likely to be Caucasians of Northern European ancestry with these low microsomal enzymes. About, depending on the study, 1/5 to 1/3 of your Caucasian patients can get in trouble with this. It's only about 1% of Asian, let's say Japanese, Chinese. I don't know about Thai or Filipino. Luckily, you can get clomipramine levels and watch this and watch symptoms. This is what I think to be the one indication for getting clomipramine levels. There is no established therapeutic range, but if before adding a non-tricyclic SRI, you get your clomipramine level, and then look at it as you're starting off every week or two, you'll certainly catch if it's starting to go up. Of course, side effects will often tell you that too, but occasionally there'll be somebody who'll get a clomipramine level of 1,000 and not show any overt increase in side effects like dry mouth. That's the big thing to watch for, is the toxicity.
Recommendations on treatment of trichotillomania.
Trichotillomania is hard to treat. The response to SRIs does not tend to be sustained. They often do well for a few months and then it abates. Behavioral techniques likewise don't tend to be exposure and response prevention type techniques. There are a number of various things that are used, some counter-irritant ways. If you're interested, Lee Baer has a popular book out called Getting Control that's mainly about OCD, but does have a discussion about some of the behavioral treatment for trichotillomania.
Is the locus coeruleus no longer thought to be important for OCD?
Locus coeruleus is the origin of cell bodies making norepinephrine. There's not much to indicate that. The dorsal raphe and other raphe nuclei may be important here, although more people think the action is on the terminals there in the basal ganglia and the cortex.
Last question, comparative effectiveness of Prozac, Anafranil, and Luvox for OCD?
Okay, there really isn't any good evidence that for the, quote, average patient, they're different. Some of you may have seen a meta-analysis that John Greist published in the archive several months ago. The problem with that, which John acknowledges and points out, was that the patients were all from different times. The clomipramine patients were treated many years ago when there weren't other treatments, and these were virgin patients coming in for treatment. By the time we've gotten around to these other agents, there are very few patients who are robust responders to something else who enter the clinical trials. Evidence from most laboratories suggests that on average with patients today, any one of these drugs will work about as well on average. But let me stress again these individual differences. We pick drug number 1 with the patient based on side effects. We talk about the whole thing, allow them to pick a drug, but we tell them at day 1, if this one doesn't work, let's go to the next one. The response rate is remarkably different for individuals.
Robert L. Horn read the questions to Dr. Baxter. Now, Pharmacology of Schizoaffective Disorder and Psychotic Depression by Richard L. Borison, Professor and Chairman, Department of Psychiatry and Health Behavior, Medical College of Georgia, Augusta.
What can we expect when brain serotonin is involved? Well, there are a number of different behavioral consequences. One can be depression, a second can be suicide, a third can be hostility and aggression. Also, serotonin may be involved in some of the negative symptoms of schizophrenia. And finally, serotonin may be involved somehow in modulating extrapyramidal motor system function and extrapyramidal side effects. We're going to touch upon all of those areas, but we're going to have a particular focus on depression and schizophrenia. First of all, is depression and suicide among schizophrenics something new? Well, the truth is, most clinicians have not heard an awful lot about it. But that doesn't mean that it's something new. It's actually quite old, as shown by Bloiler in 1911, who identified the suicidal drive as the most serious of all schizophrenic symptoms. So this is something that has been recognized for some 80 to 90 years. In fact, when the World Health Organization did a study following patients over 5 years after they first presented for psychosis or schizophrenia, they found that the leading cause of death among these schizophrenic patients was death secondary to suicide. It is common, and it is obviously a huge problem. Whether we look at attempted suicide or completed successful suicides, something that underlies all of this is the fact that schizophrenics become depressed at an alarmingly high rate. And the parasuicides or suicide attempts and the completed suicides seem to be very heavily related to depression and schizophrenia. In a sense, it's almost as if DSM-3, 3R, and DSM-4 have done a bit of a disservice by trying to move out mood disorders from schizophrenia and have us almost ignore some of the mood disorders that we quite frequently see among our psychotic or schizophrenic patients. Sampling of the literature of different studies that have looked at the rate of depression among schizophrenic patients, following them anywhere from about 6 months to about 6 years. We have things where we have something as low as about 16% of patients developing depression, up to about 54%. In general, it averages out to about 40 to 45% of patients, schizophrenic patients, will develop a depressive episode within 5 or 6 years if you just follow them long enough. A study that was looking at the percent of patients with depression, schizophrenic patients who were depressed upon admission. 40% of patients, schizophrenic patients who were admitted to hospital, were depressed upon admission. 1 month after discharge, 40% were still depressed. 1 year after discharge, 40% were still depressed. About 5 years later, still nearly half of that 40% of patients remained depressed. Bottom line, depression among schizophrenic patients is very common. Bottom line, conclusion number 2 is it is often unrecognized and untreated. What I've done is to just collect a number of different studies looking at patients attempting suicide or parasuicide, suicide attempters among schizophrenic patients. These included VA inpatients. These were patients who were followed in some cases for a number of years, etc. The percentage of patients who were followed in these studies who actually attempted suicide. And there's a range here. I think the low number is only 8% in one study, and the high number is 55%. So if we take all of these studies and put it together to try to get some concept about what percentage of schizophrenic patients may attempt suicide, about 33%. As we'll see, other people have guesstimated that that's pretty much where it is. About 25, 1/4 to 1/3 of schizophrenic patients may attempt suicide at some point during their illness. Tom McGlashan has followed schizophrenic patients for very long periods of time, from point to first admission, 15, 20 years out. And basically what he finds is about 50% of schizophrenics at some point during their illness will become depressed. About 40% of all schizophrenics will develop suicidal ideation at some point in their illness, and about 25% of schizophrenics will attempt suicide. These are really very large and very frightening numbers. If we look at some of the factors that may help us define or get a better sense for which schizophrenics are most likely to attempt suicide, first of all, about 70% of them will overdose with some type of medication, often their antipsychotic medication. Gee, we think it's good when schizophrenics take their medication. Here's one example where it isn't so good. Almost all of these patients had a previous history of psychiatric hospitalization. But there are a couple of risk factors that we're often used to as risk factors for major depression that are not risk factors for schizophrenics. Only about 10% of attempted suicides among schizophrenics, in only about 10% of cases is there a family history of suicide, and only about 20% involved alcohol or some other drug. In general, the male suicide attempters are going to have a history of more psychiatric admissions. They're the patients who also are more likely to have dropped out of treatment. They have not recently received psychiatric treatment, and they've probably discontinued their antipsychotic medication. I really didn't intend to address it, but I'm going to very briefly address it with you right now. Some people in the past have believed that antipsychotic medications may cause depression and suicide attempts and suicide. The overwhelming evidence is that that is not the case. And in fact, keeping a patient on maintenance antipsychotic medications is one of the better ways to try to decrease the risk of attempted or successful. And the most significant factor when you look at schizophrenic patients who've attempted suicide, you see depression staring you right in the face. Please, let's not think like a book or a manual and believe for whatever reason that schizophrenic patients can't become depressed. They can. They do, they will, and the consequences can be severe. Now, if we look at what happens to actual suicide rates among schizophrenics, 5 different studies looking at patients who went on to successfully complete a suicide. And if we add all of it together, we have a suicide rate among schizophrenics of about 8%. And in general, it's been accepted that the suicide rate among schizophrenics, successful suicides now, is about 8 to 10%. If we talk about major depression, it's about 10 to 12%. So schizophrenics have a completed suicide rate that is almost as high as patients with major depression. But for whatever reason, it seems like that fact often falls between the cracks, and somehow clinically we are less sensitive to suicide or the risks of suicide among schizophrenics than the risk of suicide among patients with major depression. Also a compilation of different studies looking at when patients most frequently will complete a suicide, whether patients were more likely to suicide as inpatients or as outpatients. Well, about 1/4 or so of suicides among schizophrenics will happen on an inpatient basis. The majority occur on an outpatient basis, and when one actually looks at the data, it becomes very interesting because the vast majority of suicides among schizophrenic outpatients occur within the first 6 months of being discharged from the hospital. Now, there are multiple reasons why we might be able to explain this. Time doesn't allow me to expand on it now, other than to say after a patient is discharged from the hospital, there is a period of increased vulnerability for that patient successfully suiciding. So we really need to be extremely cautious with our schizophrenic patients at that period of time. Does attempting suicide put a schizophrenic at risk for later completing a suicide? And the answer is absolutely yes. In general, about 50 to 60% of schizophrenics who successfully suicide have a past history of attempted suicide. So we should definitely look at attempted suicide as a huge risk factor in our schizophrenic population for later suicide.
Dr. Borison's observations continue on your next issue of Audio Digest Psychiatry, produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1997.